Assalamu alaikum. Good morning, everybody. So let us now come back. I want to congratulate the Medina Cardiac Center and the Saudi Heart Association for holding this important meeting on prevention. And in particular, I want to thank the organizer, Saleh Al-Gandhi, Dr. Osama Moody, and the president of the Saudi Heart Association, Khalid Habib, and many distinguished people here. I want to start off by thanking Professor Al-Nouza for his pioneering work. I heard his work many years ago. I'm going to, in the next 25 minutes, unless the camera people interrupt me, going to speak about the global situation in cardiovascular disease and what the World Heart Federation is doing. These are the data from the global burden of disease between 1990 was 12.3 million in the world. CV deaths in 2013 is 17.3 million in the world, and there is a change of 40% increase. So you will see there's an increase over these 13 years of 40% in the global burden of disease. But if you look at it, a good part of it, 25% out of the 41%, is because there were more people in the world, so there would be more disease. And if you look at the percent due to aging, there's a 55% increase due to aging. So once you take aging and the increase in size of the population into account, there is a decrease by 40% in age-specific cardiovascular disease in the world, and that is good news. That means we made progress. Now, to understand why different parts of the world had different rates of cardiovascular disease, we designed the PURE study, and at that time done in 17 countries, 154,000 people in 628 communities. And we looked at an integrated score of risk. And because at this stage that 80% of cardiovascular disease were meant to be in poor countries, we expected the highest rates of risk factors to be here and the lowest rates to be in the high-income countries, but we found exactly the opposite. There was more risk factors in the rich countries and the least in the low-income countries. Now, as expected, we found higher rates of risk factors in urban areas compared to rural areas, in the low-income countries, the same in the middle-income countries, but a reversal in the high-income countries. But the biggest surprise was when we looked at the cardiovascular disease event rates. It did not parallel the rates of risk factors. Major cardiovascular disease was actually highest in the poor countries and lowest in the rich countries, with the middle-income countries being in between. And when you look at fatal cardiovascular disease, you will see a marked difference, and death from any cause is a marked difference. But part of the story is here, because what is happening is in the rich countries, they do get a lot of cardiovascular disease, but you detect it early and you intervene early so that you prevent a non-serious condition becoming serious condition. So this is telling you about healthcare, and overall, the rates of all cardiovascular disease are the same. This was published in the New England Journal about a year and a half back. We know that 4 simple treatments in secondary prevention makes a big difference. If you did not treat anybody, you'll get an 8% per year recurrent event rate in those with vascular disease. If you give aspirin, you can reduce the risk by a quarter, so 8 will go down to 6. If you give beta blockers, it'll go down by a quarter, and 6 will go down to 4.5%. And lipid lowering, if you give a low-dose statin and you reduce LDL by 1 millimole, 4.5% will go down to 3%. And ACE inhibitors, if you give it, it'll be 25% lower, and 3 will go down to 2.3%. So if you give all 4, 8% will go down to 2%, which is a 75% risk reduction. So this is a huge advance, and we have the tools. However, sadly, the use of these simple drugs are low worldwide. So you can see the use of antiplatelets, even in rich countries, several years after the coronary disease, usually 5 years, in the community, and this is Canada and Sweden. You'll see only 40%. upper middle income countries, it's lower. And in low income countries, it's under 10%, higher in urban, but so much lower in rural areas. This is even simple aspirin. If you look at beta blockers, you're seeing that same pattern. And if you look at ACE inhibitors, the same pattern. And if you look at statins, it's even more marked, with hardly 2 to 5% of people in the low middle income countries and the low income countries getting statins. And throughout urban, the use is more than rural. Now, we try to understand why this is the case, because we all think these drugs are widely available, and that is true in the high income countries. They are widely available in urban and rural areas, but in upper middle income countries, you'll see a drop, and low middle income countries a further drop, and low income countries other than India, in the rural areas, all 4 drugs were not available. This is a surprise in the 21st century. But if you look at India, which is a low income country, the use is wide because of the large generic industry. But if you look at the cost to pay, you will see the cost of a month's medication is under 3% in rich countries for a household. It is higher in the upper middle income countries and low middle income countries. And in low income countries, in urban areas, it is 18% of a household's income. So, and in the rural areas, it's about 45–50%, but India is also the same. So do you really think people will use these drugs if one person's medicine is costing anywhere from 10 to 40% of a household income? So until we have strategies to make the drugs low cost and available everywhere in the world, we cannot benefit from this. So we need a global initiative, just like there was an HIV initiative in Africa of controlling the use. And one of the things we're working on is a polypill that can be marketed at less than 5 cents a day. That is marketed. The actual cost of production will be 2 cents a day. Now at that rate, you will see that at 60 cents a month, we can treat even the poorest countries. And this needs a global initiative, because no pharmaceutical company is going to do that because they won't make profits. So I will appeal to people all around the world, if you know of people interested in supporting reducing cardiovascular disease globally, invest in developing the polypill. You'll make a huge impact. You will save between 2 and 3 million premature deaths every year in the world. Incredibly cost effective, and it'll be in rich countries and it'll be in poor countries as well. And then if you look at the proportion of people who could not afford these drugs, you will see in the rich countries, everybody can afford it. It's only a matter of taking it. Upper middle income, you'll see households, only 18% of urban and 37% could not afford it. And as you go down to the poor countries, look at this, 80 and 70% in rural areas cannot afford it. These are data published by my colleague, my student in the Lancet recently, Rasha Khatib, who's from Palestine. She came and worked with me for 4 years, and she got this paper. Now, if you look at the rates of use of medicine, of course, if the medicine's not available, the use is 90% lower. And if the medicine is available but not affordable, it is 75% lower. So the single biggest risk factor for not using the medicine is lack of medicine or unaffordability. So simple. So it's a social reason, it's not a medical reason. Now, let us take another simple condition, hypertension. And hypertension, the prevalence is between 30 and 50% worldwide, and it's about 40% in high-income countries, upper middle-income countries, and actually in Saudi, it'll likely to be, and you will show us data, so I'm not going to tell you what it is. But you will see awareness, even in rich countries, is only 50%. And you will think about it and say, measuring a blood pressure once a year in people is so simple. But the majority of doctors don't do it. So it's a simple way of opportunistic screening. Now, once diagnosed, in the rich countries, practically all get treated, but in the poor countries, only 3/4 get treated. But the treatment is not done well. Even in the rich countries, only 20% of hypertensives are controlled, and in the poor countries, only 10%. And the reason for this is people use low doses of one drug, and we know single drugs don't control blood pressure. And the idea of using one dose of one drug and then saying, okay, if it doesn't work, I will use the second drug. But in reality, patients won't come back. And second is the doctor forgets to titrate the second drug. So if you go low dose one drug, full dose one drug, low dose second drug, full dose second and third and so on, it's impossible to control hypertension. So this is again where a polypill of 3 blood pressure lowering agents at low doses will have a big effect. So when the patient comes, if the patient's hypertensive, you give a polypill, low dose. If they tolerate it and the blood pressure is not exactly where you want, you bump up the dose. And you can have different kinds of polypills. So a polypill can revolutionize what we do in cardiovascular disease. The third one is smoking. And I'm deliberately showing data on women rather than men because everybody knows that smoking in men kills them, but smoking also kills women. And I'm afraid in many parts of the world, including the Middle East, smoking is increasing in women. And these are data from a UK study on 1 million women, and they asked them about smoking. And even light smoking of 5 cigarettes a day will double the risk of heart disease and double the risk of stroke. And you will see if somebody smokes 20 cigarettes a day, that is a 600% increase in risk in women and in heart disease, and a 400% increase in risk of strokes. And all forms of smoking are bad. You know, cigarettes are bad, BDs in India are bad, shisha, which you do in this country, is bad. We have data from Interheart and Interstroke showing that. So every form of tobacco is bad. So bad that if you give tobacco as a rectal suppository, it's also bad for you. Now, these are data in the UK showing you deaths in males from 1960 to 2010 over a 50-year period. In 1960, a 35-year-old man, by the time they reached 69, 42% were dead. Now in 2010, only 20% are dead. So there's a 23% absolute reduction in mortality. So out of 100 people, 23 more people are living till then. But if you look at that, the biggest decline is in deaths among smokers from 19 down to 4. That is 15 out of that 23, or 2/3 of the reduction in mortality in the UK is due to reduced smoking. Isn't that huge? Huge. So if we did 3 things, just 3 things, okay, get people to stop smoking, check their blood pressure and control hypertension, and give them simple secondary prevention drugs, you will reduce mortality by a huge amount, 50%. And in a country with a special circumstance like Saudi Arabia, obesity control. If you just did 4 things and you closed all your cath labs, all your surgical programs, you will reduce mortality by 50%. I'm not telling you to close everything. I'm just trying to say that as an impact. But in this country, you're putting much more of your resources into the high tech and practically nothing into prevention. And this is where I congratulate the Medina Heart Center for their community-oriented program. This is the big thing that Saudi needs, in fact, most countries in the world needs. Now let us look at tobacco. In the developed countries, there are 2 million deaths. And in the developing countries, and India and China alone will give you 2 million deaths. And every year in the world, out of the 53 million deaths, 6 to 7 million deaths are due to tobacco. 1 in 10 deaths. This includes children as well, and babies and mothers and all of that. And this will rise to 10 million deaths by the next century. Now, in the first 20 years of this century, there will be 100 million deaths from tobacco in the world. Between 2020 and 2050, it'll be 250 million. And in the second half of this century, it will be 500 billion. So who are we talking about? We are talking about us, we're talking about our children, and we're talking about our grandchildren. So that's what we have to think about. Now, in the last century, 100 million people died from tobacco. in this century, 1 billion people will die from tobacco. So don't you think tobacco is something we really need to focus on? Now, the UN target by 2030 is to reduce tobacco by 1/3. But one of the main things is in many countries, the biggest producer of tobacco is the government, like in China, and they make a lot of money from taxes. Now, one way is if real price of tobacco stays constant and smoking is reduced by 1/3, governments are afraid they will lose 100 billion. Now, in this country, probably this is not an issue because the government doesn't tax. So is that true? Does it tax? But you must start taxing tobacco. You must, in most countries, like in Canada, 75% of the cost of tobacco is the taxation. But if you double the price of cigarettes, smoking will reduce by 1/3. You don't need to do any health education. It'll immediately drop. And the government will gain $100 billion a year. And maybe you can overcome your oil crisis. So tax your tobacco, health will improve, and your finances will improve. So think of that. And these are the 4 things that we have to focus on: tobacco, blood pressure, blood lipids, and adiposity. And if you reduce blood pressure by 20 millimeters in somebody with very high blood pressure, you can halve vascular mortality, but you can easily reduce blood pressure by 10 millimeters in hypertensives, which means you can reduce it by 1/4. That is easy. If you reduce LDL with a fair dose of a statin, you'll reduce it by 2 millimole, which will reduce cardiovascular disease by 40%. But if you reduce it by even half that, 1 millimole, which is easy with a moderate dose statin or a low dose statin, that will reduce cardiovascular disease by 20%. So 25% from hypertension, 20% from lipids, and 1/3 reduction from controlling tobacco. Isn't that an easy sum to add up? Easy to say, hard to do. And in countries with obesity as a problem, a 10-unit increase in BMI or decrease in BMI will halve MI and strokes. Now, I don't know what I know what the mean BMI in Saudi in our studies is, but I'm not going to tell you, you'll tell us. But imagine that the mean BMI can be reduced by 5 units. 5 units will reduce it by 1/4. So you add those 4, the 1/3 from tobacco, 1/4 from hypertension, 1/4 from lipids, and 1/4 from adiposity being reduced, and you do not need a Nobel Prize winner to tell you you can virtually wipe out cardiovascular disease in Saudi Arabia. So now in the PURE study, this is the first thing, we said, where does the cardiovascular disease come from in the population? 5%, just like in Saudi, said they had cardiovascular disease, but 20% of the events in the community comes from there. 40% said they had a hypertension or a high blood pressure, but 66% of the event comes from there. Tobacco, 20% smoke, but 30% of the events come from there. So if you intervene in these 3 groups, it's half the population, but you prevent 80% of the disease. And I haven't even thrown in lipids. Now, the UN General Assembly 5 years ago passed a resolution that we want to control cardiovascular disease and all non-communicable disease death rates by 25% by the year 2025, and that's called 25 by 25. And we said, looking at what I showed you in the previous slides, if we just base it on 3 things, don't try to do everything. Reduce tobacco, improve hypertension control, improve secondary prevention, and in the case of Saudi, control obesity, you will easily be able to reach that goal. And so we created 3 roadmaps. And these are things that you can use in this country, in Medina, to have a community-based program. So the roadmaps go beyond guidelines. They're not guidelines. They're saying we have proven something, but how do we translate that into practice? And that is an implementation strategy of evidence-based policy. And first, we try to understand what are the barriers. Are the drugs not available? Do people not want to take the drugs? Do people not measure their blood pressure? And when they are measuring their blood pressure, the doctor's not treating them. Or is it that they're eating too much food? When I went downstairs at breakfast, which many of you did, there was clearly a young man, but he had 3 full plates of food for his own breakfast. And you know, I looked at that and said you could feed an entire village in Africa for that 3 plates, as we discussed last night. And then we need to integrate policy, health systems, and clinical approaches. This is particularly relevant for this country. In most countries, politicians, and in your cases, kings and princes, want to have a big impact in 2 years, so they build a hospital. Okay? But if you build a community program, there is nothing to show for it. When you save lives, nobody tells you I would have been dead because you did something good for me. Okay, whereas you do an angioplasty in somebody with a severe heart attack and you save 1 out of 100 people, then you'll say, oh, I saved that life. But what about the lives you save through prevention? Prevention is silent. So you have to convince the policymakers and the government that prevention is so important. And so I hope your king will support a countrywide program for the control of cardiovascular disease rather than building 100 new hospitals. Primary care is where you have to invest. Tobacco, we have roadmaps for the tobacco, hypertension, secondary prevention. But whatever we've created globally, you need to take that and make it culturally specific. Diets are cultural, smoking habits are cultural, and going to a doctor is cultural, so we need to do that. And we hope Saudi will be the first country in the Middle East region that will adopt this. Then you need to monitor progress. You need statistics. Wasn't it a little embarrassing that the previous speaker said, in Saudi we don't have good data on cardiovascular disease incidence and the changes. And you're a rich country, lot of resources. Now, if Senegal told me that, I'd say, okay, I can understand that. But Saudi, that doesn't make sense, you know. So we need to create systems to monitor national mortality, and you have national mortality, and you should get the government to publish it every year, and you can integrate it over time. And in one of the later talks, I'll show you how national mortality data really help you make national policies and save lives. Numbers on pieces of papers saves lives. They save as many lives, if not more lives, than all the complex procedures we do. And then we create a knowledge bank. In Saudi, create a local bank. So whatever the Medina Cardiac Center does, publish it, have it available on a website. Then maybe Jeddah or some other city can say, well, they made it work in Medina. I can make it work in my place. So create a national knowledge bank on prevention. And these are the 3 main publications. They're all available for free in Global Heart. This is on secondary prevention. This is on hypertension. This is on tobacco control. And the second thing is you need to build capacity. It is very common for doctors to go and train in high-tech specialty. Like whenever you ask a cardiologist, what do? You get one of 2 answers. I'm an interventional cardiologist or I'm a non-invasive cardiologist. Nobody says, I'm a people cardiologist. You know, so we treat echoes and we treat stents, but we don't treat people. Where have the people gone in medicine? So we have to now change our values. Yes, we need the high-tech people, definitely. They've made a lot of good, but we also need the people who will talk to patients, who will talk to families. And it may not be doctors. It may be non-physician health workers. So we created the Emerging Leaders Program, where we'll train 25 people every year for 5 years, and we hope again to raise money to continue this indefinitely. These are people at mid-career, like Khalid was one of our emerging leaders. And you train them in how to change policy, how to change practice, how to overcome the barriers. So we've trained 2 batches of 50 people. The 3rd batch is going to be trained next month, and we rotate the meetings around the world. The first one was in Hamilton. The second one was in Lima, Peru. The 3rd one is going to be in Bangalore, in India. The 4th will be in Beijing. And maybe the 5th one will be in the Middle East. But, you know, and so on. And the people who actually did the work was Mark Huffman and Darwin Labart, and I was sort of like a mentor to them. The second thing is we are creating a course for family doctors in primary care for cardiovascular disease prevention. Of course, this is if you have family doctors in the country. Otherwise, you could say nurses can do that, non-health physician. And we have a similar course for this in diabetes that the International Diabetes Federation did. And this is a 1-year course with a diploma, with 1 day a month they come to a city and they have an intensive course with a specialist, 12 modules, and in between they do online training. And then they write an exam and they pass it. This course is now training 5,000 people in diabetes every year in India. Our goal is to do the same thing for cardiovascular disease and eventually to take that course and give it to every region and say you adapt it to your region and train these people. The polypill, as I told you, is very important. It needs to be on the essential medicines, and I'll just skip this, but first we start with secondary prevention, then we go to high-risk primary prevention, and everybody is needed in improving prevention. And you will see there's an article published in The Lancet in 2015, March, on the vision of the World Heart Federation for global prevention. So I'll summarize with 2 slides. To reduce cardiovascular disease by 25% by 2025, we need to build partnership across health disciplines, medical and non-medical. The community is very important. And I was so pleased to hear that the Medina Cardiac Center in their prevention programs have community leaders involved. You are actually more important than the cardiologists. And you need medical and non-medical organizations, and the government is so important. You need the government on side. You need good health information systems, because without it, you don't know if cardiovascular disease is going up or down. And I would focus on these 3: tobacco, hypertension, and secondary prevention. They're easy to do. And you need to integrate care so that when people get care in a cardiac center, what happens to them when they go into the community? What happens to them when they go to their home? So you need an integrated system from the specialist center to the primary care physician to the home, where the family takes on the care. The next thing is you need improve access and affordability of key medicines and healthy foods, knowledge translation, and engaging civil society. And we need large studies like the PURE studies. PURE is now in the Riyadh region, but it really needs to be spread throughout the country, and it will be a valuable resource for the country. So I will leave the last slide up here to remind you that the World Congress of Cardiology is going to happen on the 4th to the 7th of June in 2016. But if you notice, the name is not World Congress of Cardiology, but it is also cardiovascular health. It is improving the health. And this one is not just for cardiologists. We expect half the people coming to be non-cardiologists, because as I told you, non-cardiologists are important. The early bird registration is by the 27th of this month. You'll save $200 if you go out straight away and register. And I hope to see all of you in Mexico. Thank you very much.